Thank you so much, Karen, and delight to be here. After all these years, you've grown so tremendously, and what evidence of the importance of teams and seeing all these new faces and new people come on and bring their momentum to this is phenomenal. So I'm going to give a brief overview of gene therapy and precision medicine, leukodystrophies. Seeing that Troy Lund was speaking after me, I thought, what am I doing talking about bone marrow transplant? So, but there's enough to talk about in the gene therapy space. And so I will give here a quick overview. And if my voice is faltering a little bit, just give me a pause, but I will hopefully hold up. So disclosures, I'm co-PI or site PI of various different trials and consultant to many companies, and a lot of what I do in partnerships with not just patient advocacy groups, but also industry. And similar to what you've shown is it really takes a village. And so I think all partners are important here. So for families, I thought I'd give a quick overview of what are we talking about in terms of gene therapy. And where better to start than just to speak about DNA as the blueprint for proteins that are made in our body and organ function and helps build our daily functions. As those genes carry defects, as many of you know, there are consequences for our function. Some of these gene defects are devastating. And what better justification to tackle the problem at its root? And this is where the field of gene therapy using delivery of healthy genes with viral vectors has come about. And in short here, you have faulty genes causing diseases. The DNA blueprint is used to make RNA, which is a copy of this DNA with instructions to build protein. And so, see if this works, yep. It doesn't reach that far. Oh, very faint. But we are now, in gene therapy, making use of new delivery systems for correcting these genes by using various modified viral vectors that we call capsids that are, in a sense, the packaging for the shipment of transgenes, of genes. And the most common ones we use are adeno-associated viruses and lentiviruses. And the difference between those two is one is a DNA virus, the other an RNA virus, but the main difference is that in size. So adeno-associated viruses are smaller, 4.7 kb, lentiviruses are larger. And why I mention this is because some of the size of this packaging matters when you're thinking about the different diseases that you're going to deliver to. So what are the fundamental gene therapy approaches we use with these two different viruses? So I mentioned before the adeno-associated virus, now here on the left, and we call this in vivo gene therapy. This is a direct, immediate delivery of the transgene with the naked virus, if you so want, that is carrying it into the target organ itself. As opposed to lentiviral ex vivo gene therapy, which is cell-based, and in that case we harvest cells from the children, transfect them with this lentiviral vector and give them back. So it's cell-based, and if you so want, indirect. And I'm going to give you now an example in the disorder I work on a lot of both of these approaches applied to the same genetic disorder, but now really targeting different indications. As many of you know, adrenal leukodystrophy can in childhood result in cerebral ALD and acute inflammatory demyelination in the brain. And in adulthood, it results most often in a different disorder which affects the spinal cord, less the brain. And we call that chronic spinal cord adrenomyeloneuropathy, or AMN. Same gene, different manifestations. And I will argue that for each one of these two manifestations, you need a different approach. So for the in vivo AAV gene therapy, we apply that for the adults with AMN, and I will speak briefly about that, as well as about applications in Canavan disease. And the ex vivo lentiviral gene therapy we use for the brain disease in children, which has now become approved, FDA-approved drug in the US. I should also mention the big success of metachromatic leukodystrophy and Limeldi. I will not be talking about that here, but I know there are others here in the room, particularly from the Manchester group, that are doing a lot in this field. So what's the rationale for using bone marrow transplantation and subsequently ex vivo gene therapy? We've known for many decades that bone marrow transplantation with donor cells dramatically improve survival. Many decades of work by Troy Lund and the group in Minnesota that have shown if you have a well-matched donor early on, you can impact survival, and these children do very well. How does this work? We think that the microglial cell death in the brain is really the key to why these bone marrow transplantations work. As I first started studying cerebral ALD, I noticed this zone of microglial cell death that ran around every lesion, and really for me was an eye-opening moment. And so what I think is happening is that bone marrow-derived monocytes enter the brain, differentiate into microglia-like cells expressing the normal ALD protein. So this is all well and good. However, if you do not have a well-matched donor, if you're coming late in this disorder, you can have engraftment problems, graft versus host disease, that can also be aggravated by disease stage. So many years ago, building on some pioneering work in France, we set out to have an ex vivo gene therapy trial where instead of taking donor cells from someone else, we harvested the cells from the boys themselves, transfected them in a dish with a lentiviral vector, delivering a healthy copy of ABCD1, and then gave these cells back to the boys after a brief conditioning, either with busulfan cyclophosphamide or busulfan fludarabine. And we watched these boys over time, and in a sense, this is identical to what happens with a conventional bone marrow, allogeneic bone marrow transplantation, with the difference that these are now autologous cells, so cells from the boys themselves. So I should mention that Limeldi for metachromatic leukodystrophy takes a similar approach. So we've treated now, both in the trial and in the commercial space, up to 70 patients in the trials that were partly reported this last week in the New England Journal. We've treated in ALD 102, 32 patients, in ALD 104, 35. And the difference is in one, we use a regimen with cyclophosphamide as conditioning, as chemotherapy. In the second trial, we used fludarabine, a less myeloablative regimen, so something that we thought was going to be less toxic. And we thought that was a good idea because we were using cells from the boys themselves. This story has another end to it, so hang on to this reference. Long-term efficacy and safety of ex vivo gene therapy remains very good. Here's analysis of 67 patients with cerebral ALD. Most patients achieved stable neurologic function without major functional disabilities. That is 63 of 67 patients, so 94%. MRI lesions usually stabilize, half of them immediately, the other half within the 12 months thereafter. However, lentiviral delivery can also increase cancer. There are advantages to having gene therapy with the hematopoietic ex vivo gene therapy approach. Because we're targeting stem cells in the bone marrow, we have the advantage of something we call hematopoietic reconstitution, which is a fancy term. We're just saying we're getting into stem cells that will provide a long-term, lifelong potential expression. The risks, however, are that it's hard to control where the virus integrates, and there's a potential increased risk of cancer if integration in cancer-related genes occurred. And unfortunately, about 10% of boys receiving ex vivo gene therapy, we see this is the case. These boys usually present with some signs of anemia, fatigue, weakness, decreased platelet counts, easy bleeding, easy bruising. This is seen after gene therapy for childhood cerebral ALD, but I should also mention here, to be clear, this has not been seen in the metachromatic leukodystrophy gene therapy trial. I also want to point out that we've had 7 cases so far of either myelodysplastic syndrome or what we call AML, and 6 of these 7 cases have all been with fludarabine chemotherapy. Now, we don't think that that is causative, but maybe it is contributing. But I will openly admit we do not understand all factors contributing, but many efforts are ongoing to improve this, to understand it. In the actual commercial realm, we are now using the cyclophosphamide chemotherapy, so the one where we've only had 1 patient so far in the last 15 years develop myelodysplastic syndrome. So just to summarize quickly, more than 70 patients with childhood cerebral ALD treated with ex vivo lentiviral gene therapy to date. 94% achieved stable neurologic function, but safety events are concerning and something that we still don't fully understand. Other gene therapy approaches, now turning to in vivo AAV gene therapy. So as I mentioned before, AMN is being targeted currently in trial using an adeno-associated virus. So we were watching the developments in the field of spinal muscular atrophy, a spinal cord disease that affects young children, and based on that, we decided to take a similar approach, packaging ABCD1 into an AAV vector, and we showed in cell culture as well as in mice that we got into the right location of the cell. We delivered to the peroxisomes, and we also got functional correction in these cells, meaning we were able to lower the very long-chain fatty acids. To make a long story short, we delivered this then in mice using an intrathecal pump. So this is going into the spinal fluid of these mice, and we were able to show when we delivered this not only in young mice, but even in older mice around a year of age, we were able to not only show the lipid correction, but also improvements in the hind limb clasping of these mice that we think is similar to the spasticity seen in adults. And so this is now has led to a first gene therapy trial for AMN that is led by the group at UMass as well as at in Amsterdam by Mark Engelen. And the infusions, as I mentioned before, go into the intrathecal space. So this is similar to when you would receive an epidural. You have a little catheter that leads to this infusion over a 3-4 hour time period. And this is an ongoing and rolling trial. So turning to Canavan disease, how would we tackle this here, and why would we use AAV gene therapy? So this is another single gene disorder due to mutations in a different gene. This is in the spartoaslase gene that leads usually to a breakdown of a protein we call N-acetyl aspartate. And so if this gene is dysfunctional, you have a buildup of NAA, and these children usually are very early on affected. They have an increasing head size, poor head control. None of them learn to sit. They develop severe seizures, so very devastating early disorder. And on MRI, you can see that myelination is very early on affected, even in the brainstem, and the NAs on MR spectroscopy very high. So Guangping Gao and Dominic Gessler at UMass created a wonderful preclinical work and over multiple generations of vector design, improved their AAV9 gene therapy approach and showed proof of concept in mice. What I find most interesting here is that even with a liver-directed promoter and IV delivery in these mice, they were able to improve survival. And so that provided the rationale for not delivering into the brain or into the spinal fluid, but delivering directly into the blood. Thinking that if we delivered systemically into the blood and even capturing some of the liver expression and knowing that a lot of the NA was also accumulating in the kidney, this would be helpful. So we are currently in the middle of a trial where we've gone from low dose to high dose systemic delivery. You can see here some of the first children we treated in our research unit. It was very exciting to bring this opportunity to families. This is using AAV9 ASPA gene delivered into children up to 30 months of age. So what do we see? We see a dramatic drop in the urine NA levels, as shown here on the right, where you can see that the levels in urine NA drop from the classic high levels into the lower range that are usually associated with mild patients, mild manifestations in Canavan patients. The same is true also for NA levels in brain, where we both see in spinal fluid NA drop, as well as on MR spectroscopy, where NA dramatically drops within the first weeks of administration. What happens to myelination? So one of the first things we noticed that within 3 months after administering intravenous AAV gene therapy, that the myelination pattern changed dramatically in the brainstem as well as in the cerebellar peduncles. So this is before gene therapy, and then afterwards you can see everything getting darker, and dark on T2 is a sign of new myelin being put down. And so for me as a neurologist, this was very convincing that we were changing something, and the dependence of myelination on healthy aspartate was critical. How did the children do? You can see here one of the first children we treated was barely able to sit independently, still needing to tripod, but then bringing hand to mouth, and still quite unsteady, but now standing and walking, and has just entered kindergarten, which is terrific and really a delight to the parents. So we don't see these dramatic effects in all children, but we have invariably seen over time better head control, and some of these children really learning to sit up independently, which has been quite encouraging. Similar to other gene therapy modalities, there are risks. There are immune responses that require steroid administration. We have to keep in mind that this liver inflammation that occurs needs to be managed. There's both an immediate, what we call innate immune response, as well as an adaptive, a late immune response that needs to be countered. And so this has really changed the field of us neurologists, who have so far in many cases been purely diagnostic, to ones that are now actively managing systemic side effects. We've treated 12 children with Canavan disease, either at low or high dose to date. We've seen decreases in urine, CSF, and brain NAA. First MRIs show improvement in myelination. I would say more and more of these children are showing ability to sit and head control, voluntary grasp. Brain swelling in this disease opens the blood-brain barrier, allows for gene delivery through the bloodstream. But we have to be aware that we need to train our next generation of neurologists to manage immune responses. And the last part, I will just spend a few minutes talking about antisense oligos, which, different than targeting DNA that I mentioned early on in the first two modalities, here we are targeting RNA. So antisense oligonucleotides, these are short, single-stranded pieces of DNA or RNA that can bind to the RNA and alter function, and often they're helping with read-through, often they're silencing toxic proteins. So this was first very successfully shown in the field of SMA, and now we've applied this to a disease called Alexander disease, where we, as you know, there are manifestations in infants as well as juvenile patients as well as adult patients that are due to GFAP mutations leading to a toxic protein. You can see inflammation in the brain. We know from pathology that this toxic protein is causing pathology in the form of Rosenthal fibers. So is there a way to reduce protein expression? And here Albie Messing developed antisense oligonucleotides and showed proof of concept in mice and rats that he could lower these GFAP levels. This he did indiscriminately, whether they were mutant or wild type or normal GFAP, and he showed that really the pathology improved in mice. So this led to initiating a first trial, and you can see here the first girl treated in our research unit with an ASO. This is a multi-center, double-blinded, placebo-controlled trial, similar to past trials. I should mention this really takes a village, many people contributing here to make this happen. So we think the rationale for the ASO trial in Canavan is scar formation caused by mutant GFAP, and using an ASO in animal models has proven that this can get better. We have now an international study to see if we can impact gross motor function in patients with Alexander's disease. Just a word about N-of-1 trials. So NLORM has enabled really proof of concept of treating individuals with individualized ASOs. This is the question of access options versus evidence, and I struggle a lot with questions around this all the time. But just suffice it to say that for TUB4A related leukodystrophy, we've now treated the first child ever with an intrathecal ASO, and it's very exciting for our team to see this little 5-year-old boy with hypomyelination, with the atrophy of the basal ganglion cerebellum, receive this ASO. It's still too early to say what the outcome will be, but he tolerates the procedure well. So I'm just going to summarize. There are many different exciting modalities underway, from in vivo gene therapy to ex vivo gene therapy, as well as targeting RNA with intrathecal ASOs. They all come with some side effects that you need to understand and manage. We are still in early days to understanding the effects of lentiviruses upon bone marrow and the insertional mutagenesis that occurs. Same goes for AAV and the inflammatory reactions upon liver and blood vessels. And we also know for intrathecal ASOs, although generally more benign, they still can cause not just post-LP headaches, but increased intracranial pressure. All of this needs to be understood, and we are now providing training to fellows in the field. So new genetic medicines allow precise targeting of genes. Clinical trials are needed to assess safety and efficacy. The same single gene disorder can require different approaches for different phenotypes, cerebral ALD versus AMN. While each class of gene therapy has unique side effects, individual diseases also play a role. We need to, as providers and also working with families, understand and weigh risk-benefit for every patient at every disease stage. And so this is becoming a complicated field where we need to really have the right language and dialogue and discourse around what are boundaries for performing gene therapy. This will not be for everyone, and I struggle a lot with the question of how are we making progress for a few but not enabling progress for all. We will have to go after diseases with high penetrance, extraordinary suffering, but we need to understand freedom of choice and re-evaluate risk-benefit at every stage of the way. So, sorry, Karen, if I went a little over, but I just wanted to also acknowledge here the families who are really the ones who are taking all the risks here and have put the trust in us, and I don't take that for granted. So big credit to all the families who are participating here. Thank you.